And we always say to kids, nothing bad's going to happen, and we give them that reassurance because we want to make them feel better.
It's a very difficult juggle for a parent not to reassure a child.
Do you think labelling or diagnosing kids with OCD is a freeing thing, or do you find that there's a lot of reluctance with the child and also the parents? We would like to acknowledge the traditional owners of the land, the Wurundjeri and the Boon Wurrung people of the Kulin Nation, which is where this podcast is recorded. And we would like to pay our respects to their elders past, present and emerging.
Hi, I'm Penny Moody.
And I'm Angie Green, and we are the hosts of It's Not What You Think,
A podcast about the horrors and hilarities of living with OCD. That sound all right? Okay.
Yeah. Annie and Lauren, thank you so much for being here today with Penny and I. Annie, I'm going to ask you first. You're the paediatrician and Lauren is the child psychologist. Would you quickly be able to explain how your roles differ or define your roles when it comes to working with kids?
Sure. So as a paediatrician, typically patients are referred to see us for something by a GP, and often it's about an explanation for something that's been seen and then potentially for a diagnosis, and once a diagnosis is made or not, then treatment. So it's a fairly linear thing, I guess, in one respect. I would always say the psychologists, in my view, are much more critical. They're experts in how we think, feel and behave, and they utilise a number of different types of therapies, cognitive behavioural therapy and so forth, which we'll discuss further today.
Yeah, and Annie, you obviously work with kids and their parents to diagnose OCD, for example. Can you just explain to us a little bit about what that process looks like when a family might come in and maybe they know already or maybe they have no idea, but just what that kind of process, how it plays out?
So, yes, there'll be a variety of reasons that they've actually sought help and their parents have taken them to their GP, or for an adolescent, they may have initiated it themselves, although that's unusual. And it might be because they're just concerned about their level of anxiety. That would be the commonest presentation, and that they can see that their child is worrying. And I think we do know now that parents are much more aware of just how much young children worry. So often it's about anxiety, and sometimes it's about noticing patterns of behaviour, and obviously the one that people talk about the most and with COVID has been more prevalent is hand washing. But I think that they're the two main reasons they would come. But I guess we should go back a step, and that is be clear about what children present with OCD, and they either present with intrusive, repetitive, often unpleasant thoughts, which we call obsessions, and then a behaviour, repetitive behaviour in response to that obsession called a compulsion, or you can have one or the other. And so sometimes it's the actual behaviours that parents notice and they might not really understand the driver of the behaviour, and sometimes it's just because they're generally concerned about anxiety. So I think that they're the reason that they come, but I think the biggest challenge we have in paediatrics and for GPs who are seeing these families is either a lack of awareness of OCD in the clinician or the parent or the child or all three. And actually then for us, I think the really important part is taking what we call the history, and that is listening to the story. And so being really patient and being very curious and trying to then allow the child the space to actually share the thoughts. So one of the challenges we have with these intrusive thoughts is for many children they've been present for a long time and they don't actually know that that's not how everyone else thinks. They don't know that the need for them to count the numbers on the number plate or repeat the numbers on the number plate until they see a different number plate. They won't know that not every child is doing that because it's completely hidden and it's not overt, and it's just their normal. So for a lot of children presenting with intrusive thoughts, it is their normal and they don't share it. And then the other side of the things they don't share is that often for young children, my experience is their intrusive thoughts are often about their parents either being killed, that's a very common one, or that some terrible harm will come to their parent. And so they don't share the thought because that will make it come true.
Yes.
Yeah.
And so there's a lot of fear in sharing the intrusive thoughts. So either they don't even think of them as abnormal, or if they do realise that actually there's something not quite right, they won't share it because there's often a harm factor in there.
Yeah.
So that was a long answer, but
that's a great
I think
answer.
I think for us it's around you won't ever diagnose OCD if you don't think about it, and then once you've thought about it, you really need to then explore it.
Yeah, absolutely. And how long does it typically take to diagnose someone, or is that just depends for each person?
Well, I think it depends on when they present.
Right.
So they will. So some children will go straight to a psychologist, such as Lauren, and the diagnosis will be made by the psychologist. For me, it would come as a GP referral, but they've got to get to the point of actually deciding that there's something that needs help, if you like, or needs to be addressed. So they need to get to that point, and then they need to get in to see a paediatrician, which at the moment is actually certainly in Melbourne is somewhat of a challenge. Not so much for the young kids, but for the teenage kids. Many of the paediatric clinics are unable to take on patients at the moment. So, but fortunately, I think that one of the things that's happened in the last few years is that psychologists have become more available, and I think that they are, very expert in this area. So
yeah, and so it could be a paediatrician or a psychologist who's diagnosing.
Yeah, or a psychiatrist.
Or a psychiatrist, of course. Okay. And just because if people just want kind of nitty-gritty details, I guess, around how it works, we won't go too far in, but is there a questionnaire that you use that you always use, say, for example, to diagnose, or does it just depend on?
So there are multiple questionnaires and scales for kids.
Yeah.
Generally, the Y-box scale it assesses a kid's obsession and in adults as well. But it's generally getting a good history, as Annie said, and also like a developmental history, parent history, and looking at all factors. There's not one quick fix. And obviously the DSM, the diagnostic manual says that the level of intensity of their intrusive thoughts and the compulsions are interfering with their daily life functioning, so social, occupational, academic, because every person has some level of rituals they perform because they like it, and everybody has intrusive thoughts. So I guess it's assessing how much are these difficulties interfering in their day-to-day life.
Absolutely,
and
how
that could take a
distressing
long
it is.
time, and how distressing it is.
Yeah, absolutely. Yeah. And also, I often hear about and also have experienced how OCD symptoms can often overlap with, general anxiety disorder symptoms, or symptoms that come from, maybe autism, ADHD. How hard is it to pull apart what's what when you're present, when you've got a kid in front of you who might be?
I think that anxiety disorders and OCD are not that difficult to pull apart. For me, I'm a bit of a simple thinker, but for me, I think anxiety is something we all experience, as we do with intrusive thoughts. Anxiety is a very normal emotion, and most children with general anxiety disorder are worried excessively, but they're worried about normal day-to-day things. So they're excessively worried about going to school. They're excessively worried about having a sleepover or going on school camp, or it can be obviously anything. But it's very much normal day-to-day life, and it's how worried they are and how much, again, it intrudes on their day-to-day functioning and the inability to actually resolve the fear. So generalised anxiety disorder, to me, is sort of a spectrum of anxiety, but it's about day-to-day stuff.
Yeah.
And it's really quite different from OCD. And that's why they've separated it out in the new DSM-5. So OCD is not now considered an anxiety disorder because OCD, the obsessive and intrusive thoughts, are not about day-to-day things. They are very unusual. They're right out of left centre. They're often very frightening and very unusual.
Yeah.
And that's quite different to what happens with generalised anxiety disorder. Yeah. And then in the case of neurodiversity, there's no doubt that there's a higher incidence of OCD in the neurodiverse population, and particularly ASD, autism spectrum disorder, and OCD commonly coexist. and probably make each other worse, as in I think it's harder for a child, in my experience, Lauren has much more experience with this, to engage in treatment.
When they have the neurodiversity as well,
When they
because they've
present
got
with
their
both.
general rigidity
Yes.
and the ASD, plus the OCD makes it's not impossible, but it's just harder because you're working with two very challenging factors for them.
Yeah. And is it often the case that kids with autism might do certain rituals which will actually be quite calming?
Exactly.
And then that can be at odds with
how
the...
they stim like things which
Yeah.
And it could not be OCD or could be part of the OCD. But getting back to what Annie said about the differentiation, OCD doesn't respond to CBT, general CBT that you use for kids with general anxiety. So it becomes very clear very early on that the kid has more obsessive thinking. So, and it doesn't work saying, using the Socratic questions of what evidence do you have if that mum or dad are going to be okay, or because
The logic doesn't work.
The logic doesn't work. So it's not easy, but it does become
Apparent.
identifiable
Yeah.
soon after you start treatment.
Yeah, gotcha.
And they can't shift as well. And there's always, if you say to someone with OCD, or how sure are you that this is going to happen, there's always an element of doubt. And they'll find every answer under the sun.
Yeah.
So the treatment approach is extremely different to generalised anxiety.
Yeah.
Good
And
point.
it's a very difficult treatment.
Yeah.
But it's really the only thing that does work for
Yeah.
OCD because of the obsessive nature of it.
Yes. Yeah, absolutely.
And anyone listening, I think you'll hear Penny and I sometimes laughing. We're not laughing at what's being said. We can just relate to it so heavily that it's, feels like we're
It's a
reading.
nervous laugh.
It's like, oh, yeah, cool.
Yeah, absolutely.
Yeah. But there's also this, we speak about misconceptions with OCD. There's also this misconception that, you can only really develop OCD later in life or like in your teens and what have you. We know, Penny and I know from lived experience that this is not the case, and I'm sure both of you have seen very much so that this is not the case. As like a ballpark, this might be a random one, but what's been your youngest client present with OCD?
So young clients present with OCD, but generally they don't do the treatment. It's about helping the parents engage in treatment for them. So I've seen kids that have been pretty much 3, but I don't work necessarily with the child. The work will be around working with the parent to support the child in becoming more flexible or identifying the rituals. As they get older, obviously becomes more obvious.
Yeah.
But some kids very early on, probably around 3 or 4,
Yeah.
it's interfering. And parents often see it that the kid's just difficult or just being oppositional because they have to do this thing before they go, or they have to make sure that their pillows are all the same, or that they have to, but it touch, their toothbrush 20 times or have 20 sips of drinks or whatever it is. They see it as just not poor behaviour, but like controlling behaviour, I guess, at an early age is probably what it's more seen as.
Yeah.
But it does affect kids pretty young.
Yeah.
And they're not able to get to school on time, or they have to sit in the same seat, or they have to have the same food. So it's a bit different, but when any of that predictability sort of changes, the kids become very distressed.
Totally. And Lauren, once a child is diagnosed, what is usually the first line of psychological treatment that you will start? Or again, is that
No,
so
absolutely.
dependent? Yeah.
The most important first-line treatment is actually psychoeducation about what OCD is, how it presents, and importantly, what the parent's role in the OCD is. Because as parents, all we want to do is make our kids feel better. So if they come to us and say, Mummy, I've had the thought that Granny's going to die if I don't do this, or we'll say, nonsense, that's just, it's a silly thought, or don't be ridiculous, or nothing bad's going to happen. We always say to kids, nothing bad's going to happen, and we give them that reassurance because we want to make them feel better. Now, OCD treatment is sort of the opposite of this. It's about teaching parents and kids that we all have intrusive, uncomfortable thoughts that we don't want to be there. No matter what we do or say, aren't going to stop those thoughts. And I try to give them an example of, and you guys do it, don't think about a pink elephant. I'm asking you not to. I hope none of you are. Are you thinking of an elephant of some sort?
Definitely not.
But I asked you not to.
Pink elephant.
So we can't stop what comes into our mind as much as we want to, but we can control what we do with it. So, and I also say to kids like, wow, I've just had the thought of winning $1 million or an aeroplane landing and taking me to Disneyland tonight. Is that going to happen? And they laugh and they say, of course not. And I say, well, why not? I just had the thought. And so if you put it like in a positive way, I say, but what happens if I pray really hard or if I'm really good? Is it still not going to happen? So you teach them, I guess, about not having magic powers and that thoughts are just thoughts. All we can do is be aware that we all get worry thoughts, me, you, everybody, but it doesn't mean that a thought is going to come true. And whatever ritual we do still doesn't make the thought come true or not. And parents, unfortunately, because they want to make kids better, often are very, very involved in the web of OCD without becoming aware that they're doing it because they want to make the kids feel better. So they'll the kid will say, Mummy, before you go to bed, you have to read this book and up until this page and I'll tell you when to stop. And it's no one's fault. It's just that there's a lack of awareness of how it presents in kids. And the kids often rely on parents for excessive reassurance, which we do because it's our natural instinct to want to.
Of course.
But reassurance seeking is a ritual. And the more you give it, it's never enough because the obsession might be, well, maybe Mum didn't hear me, or maybe she made a mistake, or, maybe I didn't say it correctly. And the more reassurance they give, the more they require it. And so the child and parent, the treatment is about exposure, what's called ERP, so exposure response prevention, which is exposure to the thought, the worry thought or the not quite right feeling without doing the compulsion, which is really hard. And the other analogy I guess I like to do it is I hate swimming, but when I put my foot in cold water, like we all, it's really cold, isn't it? But we're brave and we're able to put our foot in again, and the second time it's not as cold. And the third time it's not as cold because our bodies have habituated or got used to the temperature of the water. The same with ERP, it's about habituating or getting used to the thoughts being there without being shocked and without doing the ritual. Each time we do a ritual, it's confirming, unfortunately, the intrusive thought or that we did the ritual and that's what caused us to be safe. So it's a very difficult treatment. It's a very hard treatment. And a lot of parents and kids are obviously too distressed to do it or their anxiety is too high. Or it's not the right time.
Totally. And that was going to be my next question of when do you determine if a child is ready for ERP, and do you find, both of you, that there's a lot of reluctancy to doing ERP? Because I'm a 38-year-old woman and I find it hard. But how do you find navigating that with kids?
There's a huge reluctance because who wants to make their kid feel bad? And essentially the treatment temporarily does make someone sit with uncomfortable emotions and short term. But sometimes obviously, and this is it, like sometimes kids are just too anxious and parents are too anxious and they're too unwell to actually be able to engage in that type of therapy, which is where they would, see Annie and get some medication to help reduce their baseline of anxiety so that they can actually engage in treatment because it is difficult.
Yeah, and I imagine sometimes, Lauren, you would maybe need to not just talk to their parents or include parents, but maybe even siblings,
teachers, friends as well.
Yes.
A lot of kids at school get their friends to do things for them. Yeah. Their friends don't know, but
yeah. So
and their friends feel great because they like helping, but it's
just fueling that cycle.
And I think that's why what you're doing is so important, because there are so many myths and misconceptions about OCD, about what it is and what it isn't. But actually the reality of what it is, very few people are aware of unless they've actually experienced it personally or close family member. And I think going back to what Lauren was just saying then is, in paediatrics, the one big difference for us is parents, and that children are part of a family, both their parents and siblings, as you say. And for young children, engaging parents very much almost as the drivers of treatment.
Absolutely.
And building their building parent capacity for discomfort, encouraging them that is compassionate, even though it's creating discomfort and uncertainty in their child, which is not what we do intuitively as parents.
Yeah.
So it's quite a different journey for parents, and we spend as much time taking parents on a journey than we do with a child. And so certainly for the young children, really working hard to make sure that you really work hard to break those myths and to really do a lot of psychoeducation about what OCD is and then how as a parent you can help your child. I had exactly the conversation around reassurance with one of my patients yesterday, and it's a very difficult juggle for a parent not to reassure a child, but actually for this particular young man, it just feeds it, and so it's really difficult.
And unfortunately, it's also very difficult for parents because they want their kids to get to sleep on time. They want them to get to school on time, and often it's just easier to just do what the kid says or the ritual because
then they'll keep going. They can keep going with their day, maybe. Yeah. But then we know
exactly
it will come back.
Yeah.
I imagine also, starting this process of VRP, you can do it quite gradually, can't you? It's not like parents are going to be like, right, no more reassurance. You do it, you build up.
Yeah.
And so that they become accustomed and the habituation can start.
Absolutely, because I guess with that, Paul, you would want to, throw someone into the deep end or flood them. So it's really important in the early treatment stages to develop a hierarchy. The kids and parents do it, and it's called, as the subjective units of distress. You start with something that's very tolerable to them and something possibly where you know that they're going to get success, or that even an old ritual that they used to do that they're not doing to build their confidence. They've got to be in control of it. But you would never say if a kid's seeking reassurance, it's not about not doing the ritual as well. It's about possibly doing the ritual NQR, not quite right. So if it's 10 times of seeking reassurance a day, giving the kid whatever, starting with four reassurance times. Or if it's hand washing, you don't say, well, going to stop hand washing because it's not going to happen, but you're going to stop when you feel not quite right. Or instead of using 2 things of soap and 10 toilet, hand rolls, we'll just use 1. But so it's very gradual. It's really important for the child to feel safe because in their mind they're doing these things to keep other people safe or their world safe. So you cannot strip it away completely.
Definitely.
And it's a long process.
Yeah. And also really important for the kid, I imagine, to feel like they know what success looks like. They know what it feels like to be like, I can do this. Yeah. This isn't, this is very much something I can achieve. Yeah.
And I also say to parents, of course, there are going to be times when everyone's exhausted and we're all human. So if you have to just engage in a ritual to get them to sleep, that's going to happen as well.
Of course. Yeah. And, I imagine there are parents out there who might have an inkling that their kid could have OCD, but they're not quite sure. Are there any behaviours that you would look out for, that you would suggest parents look out for? Or, I guess on top of that, are there any sort of questions you could be asking your kid if you think they might have OCD?
I think one of the things that is worth, particularly for primary school-age children, a lot of parents will say to you that they've noticed that there's a particular time of the day that is really challenging, often related to either getting ready for school, getting ready for bed, and those sorts of things where that child takes just so much longer than the other children or that they would expect. And if that's the sort of thing that often parents can actually then start to be curious about and say, so spend some time with the child to say, so what's happening here and what is it that's actually taking so long to get to bed? I don't know if that quite answers your question.
Yeah, it does. I've heard a lot of parents say talk about the bedtime routine and how things have to be just so for their kid to actually be able to get into bed. And I love, Annie, that you say just get curious about it, because it's not like you're going to just find the answer straight away, but just sometimes asking a few more questions, even if they might not know what the answer is, or they might not know what their feared outcome is if they don't perform whatever they're doing. But being aware and starting to ask a few questions might actually, kind of help you in the long run.
And a very big indicator as well, and I'm speaking a lot about reassurance, but is kids seeking a lot of reassurance, and that's a very early sign.
Very common.
And saying, oh, Mummy, do you think my friend was upset with me? Or Mummy, am I going to get sick because someone touched me at school who was sick? Or Mummy, I'm not sure if the yogurt tasted funny. Do you think I'm going to get sick? Or Mummy, so it's just very gentle discussions with the kids. My kids are very good at it. They'll come and say, Mum, I've had an intrusive thought that, but it's, I love that.
Gets the DSM. I think
but it's just, using the language, it sounds like you're having some worry thoughts. So that must be really uncomfortable. Or, everybody has worry thoughts. Is this what's happening? Okay, well, tell me a bit about it. And like in a very gentle way. And it's the same if you see kids doing, getting in and out of chairs or going back into the house to check, rather than saying, you don't need to do that. What are you doing that for? Hurry up. Saying, I've noticed you're doing these behaviours. Can you tell me about it? Or do they make you feel better? Do they make you feel like you're going to have a good day? Or do you think, just general, do you think that they're going to make good happen?
Yeah.
Very
or like
gentle.
how would you feel if you didn't do them?
Yeah.
So just being kind of like
very
really curious
gentle
around.
Curiosity.
Yeah.
And that's the best way
and
to
I think
sort of
there's
get it.
also, one of the things that has happened is that families are now very busy, and a lot of families are very tightly scheduled, for want of a better word. And so everyone's on, there's quite a lot of time pressure. And there's one thing about repetitive behaviours, they take a lot of time.
They do.
Yes.
And a lot of time.
And if you interfere, they have to start it again.
Yeah.
Absolutely. And so that they are doing something that is actually holding everybody up or holding up their parents, getting them to sleep, for example, or holding them up, getting people going to school and so forth. And so they're taking time out of other people's day without people actually understanding why.
Yeah.
And then, as Lauren said, if you interrupt, and then they actually have to start again.
Yeah.
And people don't actually understand that's the rule, and that's what you have to do.
And the distress for the siblings as well, because the siblings are late and everybody's screaming, and these kids are just so distressed if they don't do it as well.
I think it's such a good point that you make, though, about coming in gently with questions, because we know that shame can really accompany OCD. And I guess when you come in with what are you doing, or why are you doing that again, it just adds to that shame that's already there.
They don't want to be doing it.
They don't want to be doing it.
It's not within their control. They have to. They feel, and that's what the compulsion is. They feel compelled to. They don't want to, but it's and that's why I guess when I work with kids, we talk about like trying to boss the OCD back, or no one likes being bossed around, and just using really strength-based language. Well, it's time for you to boss it back, or
You, Lauren, sorry if I've got this wrong, but before you mentioned to Annie the role of medication, what does the, Annie, I might ask you this question if that's okay. What are your views with children on medication, and do you think that there is an appropriate age to start, or is it not about age? Is it purely the severity of symptoms? What are your views on medication in children with OCD?
Yes, so I'll go backwards. So the answer to the question is, based on severity of symptoms and not on age. We would almost always utilise an expertise like Lauren's, and utilise ERP if a child can, or parent psychoeducation if they're younger, and you would do that first. And then it would usually be a period into that where it was becoming clear that actually the level of distress was just too high for the young person to engage in ERPs, that then often I would get a phone call from Lauren to say, I think that actually we're going to need to utilise the medication so that actually they can then do the ERP. So I think that the important role of medication is to enable the psychological therapies to be more tolerable and to work. And they do work. There's no doubt about it. It's slow and it's very hard, but they really do change outcomes. So the role of medication is really to support that. Just to go back a step, so many people will have heard of SSRIs, but basically serotonin is one of the chemicals in the brain. It's a neurotransmitter, and it plays a really crucial role in mood regulation for all of us. And so most people have now, in 2025, heard about serotonin. It gets a lot of press. But the main group of medications we use are called SSRIs. So they are selective serotonin reuptake inhibitors. So in essence, what that does is the medication slows down the reuptake of our own serotonin, so that we have more serotonin of our own. So you're not supplementing serotonin. It's around saying we've got more of our own serotonin bathing our neural cells that actually allows better mood regulation. So that's how they actually work. The ones that we use most commonly in Australia that are TGA approved are certainly sertraline, both in the paediatric and the adult space. And interestingly, fluoxetine or Prozac, which many people have heard about, which we use very commonly in generalised anxiety disorder, also works for OCD, but probably sertraline is something that most of us would use as first line. The principle for this group of medications are you always start low and go slow. SSRIs take at least 4 to 6 weeks to be effective, sometimes even a bit longer than that, so that we would usually start on a low dose and wait. My practice is to wait 6 weeks before increasing the dose. They're remarkably well tolerated. Very few of my patients have come off medication because of side effects, and I think that's because quite often you don't need to use that much, although I will say that it is not unusual for children and young people with OCD to need much higher doses of sertraline than you would use for generalised anxiety disorder or for depression. So that I always make parents aware of that, because parents all talk to their friends and colleagues and cousins and so forth, and they'll say, oh, my child's on 150 milligrams of sertraline, and they'll say, oh my God, that's way too much. My child's on 25 or 50. Yeah. But actually the treatment does need higher doses. But if you start low and you go up slowly, it's really very well tolerated in terms of side effects. The commonest side effects are sometimes some restlessness or some insomnia and nausea, which is a not uncommon side effect with many medications. I mean, as with all medications, you can get side effects, but they tend to be very much dose related. And it's quite unusual, in my experience, to need to stop medication because of side effects. Sometimes we need to actually decrease the dose, but usually it's, as I said, very well tolerated. And yes, in terms of the decision to do it, it's based on severity. Yeah. Would I use it in a young child? Certainly, yes. Primary school age children tolerate the medication well, and it helps them feel significantly better.
Yeah.
Do you find, Annie, that most kids who will start it will continue on as they get into adolescence and then maybe even adulthood?
Yes, it's a good question, and I think it's something that the parents find challenging, and that is, is this a medication that my child's going to be on forever? I think that the only truthful answer is actually everyone's journey is different, and actually you're really not going to know until you know. And in my experience of having children who I've looked after over a long period of time, they often choose. So if you say to them, would you like to wean the medication down and see how you manage without it? Quite often the kids with OCD will say thank you but no.
I can understand that.
Whereas kids who've had either issues with mood and lowered mood and depression or with generalised anxiety disorder, it's the opposite experience is, okay, you've been through a challenging time, things are looking really good at the moment, would you like to wean? And they often say, okay, let's give it a go. And I use the example, for example, of people with asthma who are able to come off their medication over summer and then the following winter they go back on it again. And it's not a pass or a fail. It's just a test. Do you still need this?
Yeah.
So absolutely, yes, there are times to reduce dose and potentially wean medication completely, but I would be very much from my view on medication, particularly with young people, is that as much as possible I try and encourage them to make the decisions about dose and timing. And I'm sort of there on the coach on the sidelines. That's what I say.
And all the research for OCD as well says that the most effective treatment for it long term is medication plus therapy because of the thoughts that the intensity and the distress associated with the thoughts that people don't understand. It's not just the rituals of tapping or things that people think what OCD is. It's so much more.
Internal distress.
I think the other thing too, just coming back to medication for a second, is that it is important for the kids and their parents to understand the chemical driver of all of this, which is actually insufficient serotonin.
Yeah.
And that actually there's very much a chemical basis for this. There's a biological basis for it, and there's definitely a genetic basis for it.
Yeah.
So there's a whole lot of different underlying factors that come into play, and there's a lot we still don't know.
Yeah, it's a really good point.
And very crucial because parents come up with all fears that it's going to stunt their kids' growth and it's going to, make them lose their personality.
Yeah.
And it's, they're never going to become, they're never going to be able to come off it, or one day when they want to become a pilot, it's going to be on their record. So
It's
the
a tough
education
thing.
about medication, as Annie was saying, is probably the hardest part for parents to be on board and understand.
And I just know that there might be parents listening to this who maybe have tried sertraline and it hasn't worked, and I just know people get stressed about medication, but just there are other options as well, aren't there?
Correct.
There are other treatments and other things that you can try. Aren't there?
Exactly.
Yeah, and you just that's
so
why.
we would start with sertraline. If that wasn't helpful, you would usually move across to in children usually fluoxetine. In adults, fluvoxamine. But there's also other families of medications that are utilised. But in children, the only ones that are actually TGA approved are actually the SSRIs.
Yeah.
Gotcha.
But for adults, there's a whole range of
you can get the SNRIs and it's
Correct.
And,
yeah.
I'm just thinking about, so I started taking medication, I think I was 26 or 27, and I'm now 38, have tried twice to go off it. My God. And now, and I don't even know why. Like
Same.
I'm like,
because you felt better and you thought you didn't need it.
and I'm like, oh my God, I'm cured. Cute. And then I was not. And I know you've worked at the Melbourne Clinic. I'm surprised I haven't been in there yet, to be completely honest, Lauren. But no, and now I'm like, and look, this is just my experience, but after the second attempt of going off it, which was so horrific, I had to move home, like I couldn't look after my children. It was horrific. And that was during COVID. I'm never going off it ever again. And I don't know why I'm saying that, but
But there's also nothing wrong with that.
No.
Mate,
and if you use the analogy, I find parents are much, much more concerned about medication for mental health conditions than they are for physical health conditions.
Yes.
So I always come back to the asthma analogy, if you like, and where everyone's totally relaxed about it, and if you need it in the winter, you need it.
Yeah.
And I think that there's no doubt at all that for some people with OCD, in fact, I would suggest many people with OCD, that they will choose to take medication long term. Absolutely. And there's nothing wrong with that. And I think the counterside of what you're saying in terms of coming off is there's often not only a recurrence of symptoms but a terrible sense of failure. And that's not helpful.
Oh, yeah, and especially with the trick about OCD, well, it's like, wait, it's come back, so it is real. So I am sick and I am dangerous, and this insidious beast that lives within me is actually me. Like, it's horrific. So Prozac all the way.
And also it's about like why you've got to look at your quality of life and and if you have to take medication for the rest of your life and be able to function and engage with your kids and be it's the same as, migraine sufferers. Why would you suffer with a migraine if you know that there's a treatment option for it?
Totally. Yeah. No, I'm so proud and happy to be medicated.
But a lot of people over time make that do that, and it's part of the treatment process. They feel better and they think, well, I don't need the medication anymore because I am feeling so better, without really understanding, well, it's probably the medication that is helping you. Yeah. And it's a journey that not only you, probably most people would experiment with.
Yeah, I've done it.
Yeah.
Let's just see what happens. Let's just see how it goes.
Why not?
Yeah, exactly. And then
it's for a laugh. Yeah.
It's part of the acceptance, I guess, process as well.
Yeah.
Do you both find I don't really know how to say this properly in terms of like pathologizing kids and what have you. Do you think labeling or diagnosing kids with OCD is a freeing thing, or do you find that there's a lot of reluctance with the child and also the parents? Is it welcomed? Is it
I think it's enormously variable. I think
Yeah,
it depends
of
very
course.
much on where parents are on the journey, and for children who are a little bit older, where they are on the journey. For some people, the diagnosis comes as a huge relief.
Yeah.
Something they can learn about. They can go down a treatment path, and we all know those parents, and they accept the diagnosis, grab it with open arms, and off they go on their journey, and spend a lot of time educating themselves and educating their friends and so forth.
Yeah.
That's at one end of the spectrum. And then at the other end of the spectrum are parents who are absolutely terrified of any sort of mental health diagnosis. And that is just part of their journey.
Yeah.
And that actually for them often they present much later because they actually don't want a diagnosis.
Yeah.
And so that's obviously a journey then you need to gently take them on. And then there's everything in the middle. So I think that I don't think there's an answer to that in terms of there's no typical. I think that some people really want a diagnosis and want to know what's going on for their child, and others are really very fearful. Yeah. And that's why what you're doing in terms of raising awareness and actually, the beast, as you say, but actually articulating much more clearly what it is and what it isn't, and trying to get rid of all of those sort of false narratives and so forth. And that means then that it's much more likely that people will come accepting of a diagnosis, knowing that there is a pathway. Part of that's around education and understanding. Part of that's around psychological interventions. Part of it may or may not be medication.
Absolutely.
And you can still do treatment with kids and parents who are not wanting a diagnosis.
Yeah.
You just have to modify it accordingly and, say it's a worry problem, or get kids to call it a name or whatever it is, rather than using OCD or obsessions or compulsions. You just
one of my patients called it no name.
Yeah.
Yeah, no name.
He labelled his OCD no name.
No name.
Gorgeous.
Oh, how beautiful.
I think as someone who wasn't diagnosed for so long, not because of my parents didn't want to, because it just wasn't just wasn't obvious.
You hit it well.
And I hid it very well. I just so wish that I had been diagnosed earlier, because I just know that they're probably, like you say, Annie, there probably are parents who are reluctant, even if it is looking quite obvious, I don't want a label on my kid, or I don't want this, or I don't want that. I just, as someone who wasn't diagnosed till they were in their 30s, I look back and I think, gosh, early intervention could have really changed my neural pathways. Like, is that something you
Absolutely,
see?
Absolutely.
Yeah.
I mean, I think it would be very, I don't know what you would have gone through, but like to experience those thoughts as a child or a teenager and then early adult, and not knowing that that's OCD would have been very frightening, and as you say, a lot of shame. And it just a simple bit of educations at schools early on about worry thoughts, what they are, and being able to have a forum to discuss it without the child feeling scared, or if I say that I have thoughts of harming someone, or people going to think I'm bad or lock me away, or if I have thoughts of, just to really, I guess, early education.
Yeah.
Really destigmatising it.
And how OCD presents, not hand washing and tap. I mean, like part of it, but it's so much more.
So much more than that. But I think the other thing too is that there's no doubt that the earlier the intervention, especially the psychological intervention, then in fact there's a whole lot of neural pathways that just don't get built.
Yeah.
And so, or get unpackaged, much earlier before they become very entrenched. And I think you would both know that the longer you have an intrusive thought for, the more entrenched it becomes and the more difficult it becomes to actually move past that. And so there's no doubt that, earlier diagnosis, earlier treatment means actually, a shorter time to actually be able to recover.
100%. And I think quite a few of my therapy sessions with our joint therapist, Andrea, is about grief, because I, even though I was diagnosed early 20s, I didn't get the specialised help, the right OCD help, until I think I was 33 maybe. And so much of my sadness is grieving a life that I never had, or was never feeling present in, because I was being conquered this entire time by something that is so insidious and horrific. And there's a lot of, not that, I don't want my life to be different, or I love where my life is at, but being like even a little bit freer from that.
It's a very controlling disorder problem, and
crippling.
A lot of avoidance or
Absolutely.
doing things with a lot more work than other people would have had to go out or to see people or to
and just so much pain,
burden.
And it's like, if I had got onto this early, and it's no one's fault, especially like I didn't know what OCD was, and everything I Googled was like different, and I was like, oh, this is bad. And so anyway, I just what personally for me, what I would have given to have a much earlier diagnosis, it just would have been life changing.
I think that's really important to. It's a grief for that, as you say, that sort of those lost teenage years where you're in your head so much of the time, because it's so time consuming, as we were talking about before. So there's so much time that you're in your head thinking.
Yeah.
And I think just coming back, the other thing is, I was just thinking before about, we were talking about the intrusive thoughts and how incredibly varied they are. And really one person's OCD is pretty much always unique. And completely unique to them compared to another person's OCD. Yes, the patterns there and the fact that they're intrusive and unusual and scary and frightening is consistent, is part of a pattern, but it's so unique for everybody. And it's the same story with, we talk about autism spectrum disorder. You've met one person with ASD, you've met one person with ASD. And it's the same for OCD. If you've met a person with OCD, you've met one person with OCD.
Yeah.
So I think that's the other message that's really important, is that it is not the same for virtually anyone. And
that's so true.
I think that's the other thing too, is we're good at putting things in boxes, but actually this is something that doesn't fit in the box.
Yeah.
You mentioned before, Annie, that especially at the moment there can be such a long wait time for paediatricians, psychologists, OTs. Even if you manage to get on a list, you can then be waiting, 9 months, 12 months. Are there any kind of tips that you can give parents who might think their kid has OCD and they want to go see a professional but they can't at the moment? What would you suggest they do in the meantime?
Well, it is very difficult, but the first thing I think people don't know about are that a lot of universities have clinics for provisional psychologists to train in, and a lot of the services are either very reduced in cost. I don't know, sometimes they might not have a cost, depends on, and so you have training psychologists who would be available to see parents, children under the supervision of their supervising psychologist. So that's always a good option.
Yeah, that's great.
Swinburne, RMIT, most of the unis have it, and it's a way that provisional psychs get their hours up.
So would you just kind of Google?
Yeah, Swinburne's got a
Latrobe, virtually all the universities
and a lot of them actually have specific. I've got a few names I can give it to you.
I'll put them in the show notes. Yeah.
But so that's always important to consider. If you can't get in, there are other options. And a lot of private clinics also now train provisional psychologists during their intern year. So even if you can't see the person that you wanted to, if a parent could be open to seeing a provisional psychologist who has great skills as well, and they are supervised.
And so they're always supervised.
They're always supervised, but there's a lot of reluctancy also. I don't want to see a provisional. But yes, they're learning, but they're not starting, they've had years of training as well.
Yeah.
So those are always really good options to be mindful of.
And then I think parents can educate themselves.
Yeah.
And I think there's a lot of work that can be done before you see someone.
Yeah.
There's so many good resources now, which you're obviously going to have in your show notes. But I think that they're coming out. It's interesting that OCD has really sort of taken off, I think, since you did your podcast in 2020.
Yeah.
And that's 5 years. There's been so much more dialogue about it, and that's absolutely crucial. But there's also more and more resources.
There's a few online. So like OCD Not Me through Curtin University, and Griffiths University has OCD Busters. There's quite a few for
really
generalised anxiety, but also quite a few for OCD that involves.
That's a really good point to make. OCD Not Me is a really good one for kids, isn't it? It's like I think it's 12 to 18-year-olds. And sometimes that's a good option, I think, also if kids are really reluctant to see someone,
Exactly.
it's a kind of good way in.
Yeah.
And these are all very research backed and can
Absolutely.
include the parents as
And
well.
some of them
I
also-
often there's actually not a lot of psychologists who are experienced at ERP in children, so that accessing a psychologist, there can be a delay. So if I see someone and the diagnosis is made, it may be 3 or 4 months before they could see Lauren, for example. Yeah. And in that time, I often do both OCD, not me, which is great, some of the online stuff for the kids, and then there's, some good resources for parents ranging from very academic books for those that want the detail. So the sort of the traditional more textbook, if you like, of this is the DSM and this is what it says, right through to just a much more relaxed way of describing what it is and what it isn't.
Yeah.
And particularly, I think, going back to Lauren's point earlier, and that is, how do parents make sure that they support their child, are compassionate to their child, but don't feed the OCD?
Yeah, it's
and I
very
think
hard.
that finding a balance of not feeding it, not reinforcing the behaviours, but how to do that kindly and gently and compassionately is really a real challenge.
It is. That takes time. Yeah, absolutely.
There's also a whole lot of, I bought some of them like books that you can buy when my worries get stuck, OCD workbooks, but it is very difficult to do those things with your kids, especially if they do have worry thoughts that they don't want to share with a parent, like if they thought harm-related thoughts or so. But there are, I guess, a guideline as well for parents to read themselves as well.
Yeah,
even if it's
absolutely.
not to work with the kids.
Yeah, so it's starting that psychoeducation before you
exactly.
get to the psychologist or the paediatrician. Yeah. And I think it might just be helpful to just note, like, that it is so. I feel like it is so hopeful. It's OCD is treatable in that it's not. It might not necessarily disappear.
Yeah.
But you can absolutely manage it.
Yeah.
If you've got the right tools and the right people.
Yeah.
Yeah.
Sorry, but speaking to you both has just been absolutely incredible. And I can't thank you both enough for your time and what you do for the OCD community, especially in kids. Your work is so profoundly important. And, to be able to share your time with Penny and myself today, I can't thank you enough. Thank you.
So grateful.
Very, very
Thank
welcome.
you so much.
Thanks for having us.
If this episode has caused any distress and you need to talk to someone, please call Lifeline on 131114 or see your local GP.